Thank you. Right, I'd like to begin today by telling you a little story about what happened to me on the weekend. So, whilst performing with my orchestra, Llanelli Chamber Orchestra, on Saturday evening, part of our programme involved symphonies by the famous classical composer Joseph Haydn. And whilst I was writing the programme notes and comparing on Saturday evening before we started the playing, I realised the parallels with what I was going to talk to you about today. There's nobody waiting outside the door. We're not going to have a stream of musicians coming through. You're all right, you can relax. Now, I could talk to you about Haydn, and I could tell you about how he was such a popular composer. He wrote 104 symphonies, and how he liked to be paid part of his salary in wine. And obviously he was very popular, he must have had quite a lot of wine. But I don't think that would go very well with the theme of the day, particularly of Non's earlier presentation about deprescribing and alcoholism and all that. Or I could tell you about how it was widely accepted the biggest mistake of his entire life was marrying his wife. I didn't say that. And that, in case you're wondering, was purely because he had designs on her sister, who later became a nun, so she was off the menu. And it was actually because she used to rip up his scores and use them for hair curlers. Don't know what happened there. But anyway, where I'm getting to is we performed two pieces on the weekend. We performed Haydn's 101 Symphony, which is known as the Clock, which resonates a ticking movement throughout the piece, which has resonated in different sections of the orchestra. And we also performed the first movement of Haydn's Drum Roll Symphony, number 103, which begins with a loud drum roll cadenza, then, for want of a better word. And I realised that that was similar to the nursing homes. And I'm on the wrong page, hang on. Right. Because in the health board, we were working, as we do, thinking that things were ticking along quite nicely in the nursing home. But in reality, things had kicked off with a big bang and we didn't really know it. So just to set the scene, the project involved a large care home in the Swansea area in which I work. It's a very large care home. It's over 120 beds, consisting of nursing, residential and dementia patients that reside within the home. And when you think about the challenges that come with that, if you put it into parallels, Neath Talbot Hospital, for example, has 132 beds and a daily pharmaceutical service. And these guys in this care home have next to nothing apart from a GP round on a weekly basis. There are 2 GP surgeries serving the nursing home. And I suppose we were called in originally, went in blind, because there were concerns from the GP practices. There were rumblings about the chaotic nature of the prescription ordering on a monthly basis, so the ordering patterns. And there was also concerns about the level of contact the GP surgeries were having, demanding prescriptions outside the monthly cycle and even on day one of the monthly cycle within the care home. And there were excessive number of phone calls on a daily basis to the GP surgery. The care homes themselves, in their big bang moment, lost the plot. The trigger was they couldn't keep up with the amount of waste bins that they had to have in the care home for the pharmaceutical waste that was generated. And I do forget, you'll have to excuse me, how many litres that equated to. But let's just say they were the waist height waste bins, similar to what we get for our wheelie bins. And they were going through in excess of 8 of those bins per month. So that was their trigger. Also, they had issues with the MAR charts, which were exceedingly lengthy for the care home. And when I sat down and did some focus groups and worked with all the key stakeholders, the community pharmacist also had issues with the amount of waste that was being generated there, because they were organising the waste disposal for the care home through a third party, and of course it was exceeding the limits. It was causing problems for the community pharmacy because the monthly prescriptions were arriving late at the store, which had a knock-on effect then on turning the prescription round over and getting the stock out to the care home. And they too had raised concerns about the level of contact they were having from the care home with regards to missing items, errors on MAR charts. So what I learned from that, and what we translated into Project AIMS, we needed to increase the efficiency of the monthly prescription ordering process in terms of accuracy, meeting deadlines, and reducing the impact on staff workload for staff working both within the community pharmacy, the care home and the GP surgery. And one way that we needed to do that was to look at the organisation and the communication that was going on. The second thing was trying to reduce the unacceptable, excessive level of waste that was occurring in the care home. And again, we felt that by getting improved control of the prescription ordering process, this would lend itself to resolve this. And the third thing was we wanted to reduce the potential to cause harm, obviously, because you're dealing with medicines and there was such a large cohort of patients. If you think about most elderly patients are on at least 6 or more meds, then obviously there's quite potential there. So we wanted to improve the quality and the content of the MAR charts, thereby reducing potential patient safety issues. So that, and again, was another communication method. In addition to this, we wanted to tackle anything that came up relating to clinical governance issues, relating to medicines usage, provide assistance to the care home as and where needed, and one of the things they'd highlighted was addressing their medication policy, and support staff who were feeling quite isolated with any medicines-related issues. So we were sent into the care home initially on what was anticipated to be a one-day project, and in reality, myself and the excellent support I had of one of our medicines management team technicians, we were actually there for intensive for about 3 months, and then that continued then at a lower level. That's why I've been let out today. Yeah. So this is the picture that we had. The care home itself was very, very large. It was divided into several units. That's how they worked. So each unit was about 20 to 30 patients. And this is a picture that we just put all the stock together just to try and, provide some evidence then for the health board in terms of the level of waste that was happening there, and that only relates to one medication room. When you totaled up for the whole building, before we started working there, the 1 month before, that equated to almost £6,000 worth of waste. So obviously I could understand then how they were getting through 8 waste bins a month. Oops. Okay, so priority number 1 then was, via the areas highlighted in the focus group, was to become, I suppose, take a central lead to try to resolve the issues with the prescription ordering process, and that involved working across all agencies. So as part of our remit, we were renewing the initial order that was placed by the care home before they'd submitted the prescription request to the GP surgeries, so filtering out unnecessary requests, spotting clinical issues, and coming up with strategies to change prescribing, looking at doses, switching drugs, querying with GPs and processing prescriptions with the prescribing clerks at the GP surgeries, trying to tighten up on their processes because the care home were getting a lot of items through which they hadn't requested using the GP repeat slips. And also improving the communication with community pharmacy. They had a regular community pharmacy who wasn't really informed very often, or was periodic, as to what the changes to all of the medications were for the residents. So we set up a system whereby there was a monthly communication sheet for the community pharmacy to use to make sure that the MAR charts were up to date and that they were quite succinct. Because when we went in there at the start, it wasn't uncommon to see a MAR chart that was about 8 pages long, which was obviously quite difficult for staff with a narrow amount of time to spend administering drugs to residents. And then the fourth and final thing was actually to start reviewing patients' medication, trying to make savings in line with health board policy, targeted prescribing, de-prescribing, which we've heard spoken about earlier this morning, ultimately aiming to rationalise costs and improve that part of the process. So it's quite a big piece of work, but I've tried to summarise the savings and the interventions and the outcomes that we did through the project. So the first one looks at issues between the GP practice and the care home. So in terms of cost, which is obviously important in the financial climate with the NHS, I analysed them on a monthly basis. So as you can see, the average cost per resident per month decreased over the first 3 months, which was the analytical period that we used. And in fact, the savings during the first 2 months came to £5,500, which was almost the same figure that we'd seen in 1 month for the wastage. What did we do to achieve these? Well, we looked at what was going on. So in the first month, obviously it was quite new to everybody what we were doing. It took a lot of communication to get things working in the home. One thing that was happening was there was a lot of wastage being generated because benzodiazepines and when required medicines were being re-blistered by the community pharmacy into these coloured blister sheets for different times of the day. And obviously when they're re-blistered, they have a reduced shelf life, typically of about 8 weeks. So they were being thrown out every other month. So we arranged with the community pharmacist that they would supply them in the original packs, the shelf life was extended and the wastage went down and the unnecessary costs went down for prescribing. In July, we'd realised as we went through the month of June, because we're always working a little month behind, that every time a new medication supply came in for that month, the care home were very religious and very, on the ball. They were actually binning any single thing they had in their cupboards, to the extent of unopened pots of creams, unopened dressing packs, and they were ordering a new supply which was being processed, and they were having that in every month. So that was obviously a complete waste and a drain on the NHS. The second thing that we did was we tried to improve the organisation there, because there were medication errors coming through. Although nothing was picked up in the most recent CSSIW inspection, there was nothing there to alert them to anything at the time. But we noticed this as we went through reviewing patients. So we reorganised their medication rooms, put it into patient sections, sorted their trolleys out, and basically put everything into the one place, because they had nutritional supplements in patients' bedrooms, they had them in the kitchens, they had them in multiple kitchens, they had them in their medication rooms. They didn't really know what they had for who, and then patients were obviously sharing, which goes against good practice as well. So that was July, so that's how we had some more savings there. In August, we had a complete audit, which we'd done looking at the MAR charts themselves, and realised that the ones the community pharmacy were using didn't have the facility for carried forward stocks to be written on there. So the care home and also the amount of stock then, which would be carried over from month to month. So the care home didn't really have any records or an auditable trail of what was left. So we had new charts from the community pharmacy, and we condensed the charts. So whereas previously every medication had been written out separately each time it was due to be administered. So, for example, paracetamol was written 4 times on a MAR chart. We had a new MAR chart, a new style, where the item was just written once with several times beside it. So that lent itself to less errors. And we also did some training with the GP surgeries as well. So as I said at the beginning, there were 2 GP surgeries. We put the offer out to both surgeries, but only one took us up on the offer, just to explain to the prescribing clerks and the GPs and the nurses the systems in operation in the nursing home and how it works, and why you get scripts through in big batches, etc., etc. Okay, so we didn't expect the cost savings to continue at that rate, but as you can see, within 3 months it was £7,500, which is obviously a considerable amount of money to have saved. So if you look at more qualitative interventions, things that we'd done and what we'd achieved, again, you can see that the intervention rate dropped slightly in July, but then picked up again in August, which was attributed to the fact that once we'd done the initial more pressing issues, we were able to get down then and start making more clinical interventions, which occurred at the end of July, beginning of August. That's why we had the rise in interventions there. I tried to categorise them so we could try to make some sense as to what we were getting at each time. So over the 3 months then, the most prevalent area of interventions that we made were in terms of changing medication. So this included changing doses, according to renal functions or age, doing drug switches if there were more cost-effective alternatives, and actually stopping and reducing medication where appropriate. I've listed all the categories there. Meds rec was another important one. Obviously within the care home you get patients transferring between sectors, whether it's from their own homes in or whether it's from secondary care back to the home. And again, there were issues there which we had to intervene. Also, there was the need to refer to other healthcare professionals, such as speech and language therapy, dietetics, the incontinence service. So that's what made up the bulk of those as well. If we look at the specific, this is a pie chart to show details of the specific interventions that we made. So the bulk of them fall in the 35% at the bottom, and that related to drug discontinuation. So I've made a couple of notes so I could remember, because obviously there's such a lot of work we did, I can't remember off the top of my head. But things that we stopped were things like folic acid, items that had been on acute that weren't intentionally intended to be continued, but which had been left on the chart and were continuing to be administered. Things like metoclopramide, low-dose steroids, painkillers, multiple laxatives. So those are the kind of things, and creams that we antibiotic creams, things that we stopped. The blue sector then on the side, the 13%, that related to referrals to other healthcare professionals, which I'd mentioned. The red colour, the 13% on the the opposite side, related to meds rec. So again, looking at discharge summaries, we found issues where there were diuretics missing, which hadn't been transcribed from hospital onto the GP records. There was issue with bisoprolol doses and DOAC doses. There was also issues in relation to changes to antipsychotics that had been made by CPNs. We picked those up as well. There was quite a bit of therapeutic duplication, so that's the yellow chunk. So we had in terms of multiple emollients, which patients were no longer using. Multiple painkillers, so we did find paracetamol coupled with codidromol or cocodamol, which is obviously inappropriate. Multiple laxatives and multiple antihistamines. We did get involved in recommending monitoring tests, so we had patients who were on iron therapies, things like that, so to do that, and things like LFTs and U's and E's where they were appropriate. And there was quite a cohort, which is the little light blue section on the top, where we had to recommend changes of dosage forms. So we had patients needed to be changed from tablets to soluble tablets or liquids because of swallowing issues, things like that. And we had things like isosorbide capsules being prescribed and dispensed by the pharmacy with a dose of half a tablet. So we changed those to tablets as well, because I don't know how on earth they were given that one. Okay. Then we looked at the interventions that we made with the community pharmacy, between the care home and the community pharmacy. So again, the first lot, it showed a general decrease over the 3-month period, so actually we halved the intervention rate. Things that we did, we recommended changes to MAR charts, so things that had been discontinued, things needed to be taken off, things that were on the charts that were actually inaccurate. We suggested adjustments to dispensing, so in terms of repackaging into original packs as opposed to dispensing into blister packs. And then we looked at the administration systems. So we had errors in patient details on MAR charts in terms of GP name, date of birth, which is obviously important when patients are moving between sectors. So generally, we were trying to improve the accuracy, thereby reducing the risks to the patient. We did have an issue in the July. We'd expected the intervention rate to be much lower because our regular community pharmacist had the list and the prescriptions and was on holiday when it was dispensed. So when we were in the home and we were seeing changes that hadn't been actioned, we went back to the community pharmacy, and unfortunately it was a locum pharmacist that was there that day because the regular pharmacist was on annual leave. And even though he obviously had the list from us, things that needed to be stopped and changed, because they dispensed them within the last 3 months, they felt that it was more appropriate to leave them on, even though we'd provided the clear indications and the instructions as to what needed to be removed and things and why. So that was a little bit disappointing, but I'm sure it's not the only place that things like that happen with different turnovers of the staff. So again, if we look at the exact things that we did with the community pharmacy, quite a large chunk involved, and it's the large portion at the bottom, the 42%, requesting a removal of items from MARS. There was a lot of items on there that were just had been stopped or needed to be stopped. Requesting time changes on the MARS, so we had care homes that had sleeping tablet on there at 10 o'clock at night when the patient was going to bed at 8, or we had antibiotics on there when the patient would be asleep, so we had to adjust that according to the pattern for the service user then. We actually asked 17% at the top in the blue for the MAR charts to be alphabeticalised because they were so lengthy and they didn't mirror any of the order that the medication appeared on the medication racks. So carers were having medication errors because they'd flipped the wrong cards and things over and hadn't checked in, and we felt that that would have contributed partly towards it, or could certainly help to minimise the risk. And then in terms of demonstrating an outcome of the impact of the project on the surgery staff workload, so we looked at a 1-week period before we started the pilot work, and then we looked at a 1-week period after we'd started, the following month after we'd started the pilot. So the pre-pilot is in red and the post-pilot is in green. The total number of telephone calls from the care home, you can see within the first week of the monthly cycle in our pre-pilot phase was 88 phone calls between the two surgeries, and in fact 28 of those calls were made on day 1 of the monthly cycle. And as you can see, 74 out of 88, they weren't actually for things like house calls, they were just for medication requests. So you can get a feel, that's about 85% of the calls, you can get a feel as to how chaotic the system was. And obviously in the green then, after we'd started working with the care home and putting the support in, the number of calls to the GP surgery on day one of the cycle had considerably reduced by nearly 80%. Same for a number of, and again, if you looked at the number of those calls that actually, were requesting prescriptions, that was a lot lower as well. So we have to obviously quantify everything within our role. So the health board wanted obviously to know how much the service had cost in terms of our input into the project, and if there'd been any financial savings taken into account our time that we spent there. So I divided it up into the 2 GP practices that we look at, because I'm sure everybody can appreciate that people have got different ways of working, and the practices were quite different and wanted to work in different ways. So for the first practice, I looked at how many patients were registered there in February 2016 and then compared it with the same figure a year later. So the number of patients were relatively constant. It was only 6 different, but the actual average cost of the patient's therapy had dropped by 50-odd%. So it's quite a big reduction there in terms of the clinical work that we've done and the reorganisation. And if you work that up, it amounted to about £40,000 of prescribing cost savings just for that practice alone. Taking off our wages then for the time we'd spent there, it was still about a 30 grand saving for the one GP surgery. If you go to the next one, the results don't look as good for that GP surgery's patient population. So same comparators again, perhaps a little larger number of differences in the patients number on the list. But again, the average cost had dropped by about 40%. So we only actually managed to save about 10 grand for the year within that GP practices, and we attributed that to there being differences between how the practices worked. So for example, in this surgery, we had GPs that would rotate the workload for the care homes, whereas in practice A, it was always the same GP dealing with the care homes. And it was quite difficult in terms of working with the number of GPs involved in the practice, because they were all part-time, and then you couldn't link up with them to work as easily as you could within the first practice. There would also be delays in the signing of prescriptions, because a lot of the time the scripts were left for that particular GP to sign when they were in on their shift, which obviously caused delays for us and the pharmacy and the care home. There was a lot of lost prescriptions because they had a centralised prescription line in the surgery, and we had issues with prescriptions going missing. And we didn't have as good engagement with the medicines management team as we would have liked, purely because of all those factors with the number of staff and things that were involved. So this one actually, I suppose, clawed back some of the savings that we made off the other practice list, and it was actually overspent by about 10 grand. But having said that, when you looked overall at the work that we'd done, it still amounted, taking both saving figures into account, to a total cost saving of about £20,000. So that was obviously quite significant, because it based, at the end of the day, it was just one care home that was based in. And I know it was a large one, but still it was just one care home. When we looked at the waste, because that was another significant factor at the outset in the focus groups, if you remember the figure, 1 month pre-pilot was almost £6,000. 1 month post-pilot, 1 year on, was £600. So we had a 90% reduction in the wastage costs as well. So that was really, really pleasing. Okay. I had some qualitative feedback off different healthcare representatives for the project. So we asked for feedback off GPs from different surgeries, the community pharmacist, and also carers and staff within, and the nurse within the care home. We worked across the 2 shifts. So we worked with the night staff as well as the day staff to achieve the project aims, which I'm sure you can appreciate was quite hard going, but it was definitely worth it. The care home was so grateful for any support, to be fair, because as I said at the start, they don't really have a daily pharmaceutical service like you would expect for a hospital of the same size. So they were really, really grateful, and the more that you were there, the more that they used you in terms of answering medication queries and anything really to do with medication and the service users. So in terms of future work and working it up, unfortunately, within our health board, we don't have much resource for ploughing any more input into the service, and we've actually had to scale back our work. So what we've had to do is look at the next best model that we can get to try to continue the work in this area. And to do that, we've looked at the community pharmacy more closely, because obviously they're in an ideal position, being the link between the two providers and stakeholders. And we've adapted the enhanced service which the Health Board offers. So we reviewed the results of this project in line with the results of feedback of our community pharmacy enhanced service that we'd run for the last few years. And feedback from the enhanced service that was previously was that we were getting the same kind of things picked up on the visit report forms by the community pharmacist, time after time, every 6 months. It was always the same issues. So we fed that into Welsh Government when they were revising the National Enhanced Service for care homes. But unfortunately, the service that was released didn't quite fit with the aims that we've picked up from this local work that we've done. So within ABM, we've moved away from the national service and we've still gone with our own enhanced service. So the community pharmacists, we've extended it to include community pharmacy technicians, because they're obviously a really, really valuable resource. They're being asked, or they can sign up to an enhanced service now where they visit the care homes on a monthly basis, specifically to assist within the prescription ordering process. So they're remunerated for that, as well as doing the medication standards audit. They are involved in the prescription ordering, and we've just finished upskilling the community pharmacy, the pharmacist and the technicians in a series of training days that we've held within ABM. So we're just waiting for the moment for data. It's in its infancy, it's only been running for like 1 or 2 months, but we're certainly waiting and keeping a watchful eye to see what's happening, because a lot of the things that we picked up in this project, different agency staff that were working within the care home, they were telling us that what practice had happened in this care home was common practice across all of the care homes that they work in, and they work in multiple places. So we've recognised that it's not just this care home who's experienced these issues, that it is there, it's widespread across the board. So there's obviously quite a lot of work to be done in this area. So that fits really, just to summarise, the first one, that we definitely need improvements in how medicines are prescribed, dispensed, administered and monitored in care homes, which is consistent if you go back to 2009 with what they found out of the CHUM study. We definitely have evidence to support the RPS and NICE vision that better utilisation of pharmacist skills in care homes will bring significant benefits to the residents, providers and the NHS in total. And again, a focus on delivering achievable and sustainable improved medicines management services to those living in care homes, and that ultimately can only serve to improve patient care. So, thank you for your time.